Okay, everybody, this is Chapter 1, Introduction to Emergency Medical Care. This is a fairly quick chapter for us to get through. I'm going to skip through some of the slides and try to keep it as short as possible just for uploading purposes. As we go along, if you have any questions, go ahead and jot them down. You can email me with any specific questions, and we'll have a continued discussion on Thursday about this chapter and then Chapter 2 as well. So if you are going to follow along, if you have your textbook, we're starting on page 2. We're going to go over some key terms that are really, really important for us to remember throughout the rest of the course. And those key terms are in the tan box at the top of page 3. There are certain things in this chapter that are more important than others, and I will point those out to you as we go along for testing purposes. But again, if you have any questions, go ahead and jot them down and just email me, whatever is easier for you. So talking about how EMS sort of came about, EMS came about in the early World War eras, and really as far back as the 1790s. And it's not the same EMS that we know of today. When this first came around, we were talking, horse-drawn carriages, man-drawn carriages, with their main goal essentially to be to get the injured soldier off the battlefield and into a field hospital somewhere. There was not much in the way of treatment. There certainly wasn't much in the way of regulations or protocols or advanced treatments. And as time passed, they became more apt to include skills in the transport. And then you can fast forward to today where, of course, we have a lot of skills and a lot of protocols in our transport. So the first non-military ambulance services started to pop up in the early 1900s, and those were operated by hospitals, fire departments, or funeral homes. In fact, Wheatfield Ambulance Service started as a Northern Jasper County ambulance service. Keener Township and Wheatfield were together originally, and that was operated by volunteers who would take the hearse to somebody's house when they were sick or injured and put them in the back of the hearse and drive them to the hospital. And that's how our very service here got started. It's how most services got started. Like I said, there were no requirements or standards for what equipment you had to have on the truck, what level of training your staff had to have, or definitely not any safety features for what sort of ambulance, so to say, you were using. So in the second half of the 1900s, we start to see more regulation and more rules pop up. One of the first agencies to start developing some standards were the Department of Transportation, because ultimately we are transporting a person from point A to point B, and the Department of Transportation to this day still has a lot to do with what we do in EMS. In 1970, we note the founding of the National Registry of EMTs, and we'll talk about the National Registry later in this presentation. But basically, it's a national bank that EMRs, EMTs, paramedics, and advanced EMTs can all be registered through by passing their testing processes. We'll talk about some of the pros to it and a little bit more about what they do in just a little bit. For testing purposes, no need to know the specific dates on anything. You're not going to be asked any questions on the dates. I'm more focused on you guys having a general understanding of how things developed over time. Okay, so the National Emergency Medical Service System Act, passed by Congress in 1973. Again, you don't have to remember that date. So just a few things that were brought up in the act. What does the act address? So one of the first things is regulation and policy. Each state sets forth the laws, policies, and regulations, the standards, if you will, for emergency medical services in that state. For example, the state of Indiana tells me how many hours of training I have to provide to all of you guys in which topic to complete the class. The state also requires certain types of equipment to be on ambulances. They have to be state inspected and state improved, and you all have to be state licensed. So the state sets those laws and regulations. Resource management. So we have to consider a centralized coordination of resource management for the coordination of our emergency treatment and transport services. So where we have ambulances dispatched from, where we have services available um, to respond to and from, and then also equipment all the way down from your normal everyday medical call up to a global pandemic like what we just experienced. How is that equipment allocated and how is that equipment managed and distributed out to the people that need to use it? Human resources and training. So we have to ensure that the people that are on the ambulances taking care of the sick people are all trained up to a minimum set of standards. We can't just say this ambulance service is rural, so they can do 20 hours of training, and this ambulance service is urban, so they should have 400 hours of training. We can't do that. There's a minimum standard that everybody has to meet. Transportation, again, we have to provide a safe, reliable source of transportation from point A to point B. What facility we go to. So this is incredibly important, and this is one of the first critical thinking exercises that we're going to do in this class, just to kind of think about some of the facilities that we have in our area, hospital-wise. Um, the rule of thumb is that you transport to the closest, most appropriate facility all the time. Certain facilities can handle certain emergencies that other facilities can't, and those are all things that we'll have to learn about and things we'll have to consider when we're making that decision. And then communications. So the universal emergency number, obviously being 911, and communications going beyond that. Dispatch to ambulance. Ambulance is talking to other ambulances. The ambulance is calling the hospital and letting the hospital know, hey, this is what we have, this is what we did, and this is how far away from you guys we are. So get ready. And then hospital to hospital communications. This would come into play with a smaller hospital having a patient that needs treatment beyond the capabilities, communicating that information to a larger hospital that is going to be receiving that patient when they transfer them out. Public information and education. Part of our role of EMS isn't just responding and reacting, it's also preventing. Primary prevention strategies that we can implement in the community, we can implement on calls at the time and the case allow, to prevent further injury or new incidents from reoccurring. Um, a great example of this is a smoke detector campaign, the carbon monoxide detector campaign, safe baby sleeping practices to prevent sudden infant death syndrome. All those things are great examples of that. And then medical direction. So we're going to talk about this a lot. We'll talk about this again when we talk about medical, legal, and ethical issues. So the medical director is accountable for EMS personnel within that system. So every hospital system has a designated medical director that is a doctor. Any emergency medical services that are sponsored by that hospital are operating under the license of that doctor. For example, Wheatfield Ambulance Service is sponsored by Porter Regional Hospital. Porter Regional Hospital's medical director sets our protocols and how we respond in certain instances. He essentially is telling us, for this case, you guys do this. For this case, you guys do this. And we will get a little bit more in depth in that here shortly. Okay, sorry, I was making sure my microphone was working. Trauma systems. So we have to develop trauma, triage, transport, and treatment protocols, all the way down from your simplest single patient trauma call, moving up to a motor vehicle accident with multiple patients, all the way up to a mass casualty incident, such as a school shooting, something that has far more patients than what one ambulance can handle. What are our protocols for making sure the most critical patients are treated with the most proper care possible in situations like that? And then finally, evaluation. So it's up to us as individuals, us as providers, and then our organizations to which we work for to establish programs for evaluating what we're doing and if we're doing it good enough. We call this quality improvement, quality assurance, and total quality management. So quality improvement and quality assurance, or QI and QA, go hand in hand with each other. We are wanting to ensure that the care that we're providing to our patients meets the standard or goes above the standard and is adequate for what they need. Quality improvement is where we recognize the deficits in either what we're providing or what we're able to provide, and we come up with possibilities on how to improve that, planning for the future. Total quality management is looking at the entire organization. So if Carter and John Doe are working the ambulance and Carter did something not right on the call, um, quality improvement would be, how is Carter going to stop from doing that, and how are we going to fix that in the future? Total quality management would be, okay, what can Wheatfield Ambulance Service do as a whole to provide a better service to the community? Or what can Wheatfield Ambulance Service do as a whole to make our employees work better together, and as a result, provide a better service to the community? So the EMS system is made up of many different parts that all work together. If one of those parts weren't there, the system essentially would fail. So starting with our dispatchers, those are obviously the people that the sick patients call when they need help. Those dispatchers are the link between our patients and us getting to our patients, and they have our backs throughout the entire incident and literally guide us all the way up until we walk through the threshold of their front door. The EMS responders, first responders, the ambulance, the fire departments, the police officers all play a role in this, believe it or not. And of course, they're being guided by the dispatchers. They respond, they assess the patient, they transport the patient, and they attempt to stabilize the patient. The emergency department and receiving hospital, made up of really all the hospital staff, they have a very important role of continuing to stabilize the patient and following up until the point of discharge. And then for certain cases, we have specialty centers. For example, trauma centers, burn centers, pediatric centers, cardiac centers, and stroke centers. Depending on the severity of the patient, the type of injury, the mechanism of injury, and the list goes on. And we will get, I promise, much more in depth with this as the class continues. There are certain hospitals that are better for certain types of patients than others, and that's all something that we have to consider as the EMS provider. So I'm going to pause for a second and give you guys a second to read this over. This is a think about it question. We'll discuss it in just a second. Okay, so what medical services are available in your community? This is a individual question, and I'd like you guys to just sort of think about it amongst yourself, because we all live at different places. So think about what EMS services are near you, what EMS services have you experienced if you've been in that situation, and if you don't know, maybe jot that down on your notepad, and that would be a good discussion to have in class on Thursday. Um, how important is it that EMS personnel know the capabilities of the community medical facilities? It's extremely important, for a lot of reasons. We need to know if the hospital that we're taking our patient to is going to be able to benefit that patient, or do we need to think about a different hospital, or do we need to think about airlifting our patient off of the scene. Um, it's extremely important to know what capabilities the hospitals around us have, because if we send the wrong patient to the wrong hospital, it could cost the patient their life. And that ties right in with the third bullet point. I didn't quite read ahead, but yeah, it up until causing death amongst the patient. If we send somebody to a hospital that's having a heart attack, and the hospital doesn't have a cath lab, and there's no hospital nearby that hospital that has a cath lab, you could potentially cause a patient, to die, unfortunately. So it's something that we really, really have to consider. Okay, so just diving a little bit more in depth to the EMS system. 911 telephone access is available pretty much everywhere. Enhanced 911 just is a little bit more in depth. It's more and more dispatch centers are equipped with it. More and more communities are able to have it, but it's just a way for the dispatcher to be able to pinpoint a little bit more precisely exactly where the caller's at, if the caller's unsure, if the caller's hysterical. Um, in Porter County, we call this phase two pinpointing, to try to figure out where somebody's calling from if they're unsure of their exact location. Okay, so dispatchers have some extra training that a lot of us don't think about beyond just answering the phone. So dispatchers are able to give instructions over the phone to the people calling about what to do in certain situations. For example, dispatchers are trained in CPR instructions over the phone, so that way the caller or family member or bystander is able to start CPR before responders are able to get there. Okay, so critical decision making. In the role that we play, it is very important that we become critical thinkers or adapt to become critical thinkers. Um, Information is going to be gathered. We're going to assess what situation we have. And then, with the tools that we have and with the information that we have to make a very quick and educated decision that we can back up. Decisions are very time critical. We don't have a lot of time to sit here and think about what we're going to do, but we do have to have a reason for why we're doing what we're doing. So here's a couple examples about some critical decisions. So is it better to take a patient to the closest hospital or to one farther away but more appropriate for their condition? And is a patient stable enough for further evaluation on scene, or should the patient be transported immediately? And will this treatment make the patient better or worse? So the first two are a case by case scenario, depending on what's wrong with your patient, where you're at. Really, there's a lot of factors that play into it, and we will have some case studies about real world scenarios that we could discuss in class as we continue throughout the course. The second bullet point brings up an interesting point, and we'll get more in depth with this when we talk about specific medical and trauma chapters. But there are treatments out there that if you give to a patient with certain conditions, will make the patient much, much worse than what they actually were. A very good example of this is oxygen therapy, actually. Back in the day, oxygen used to be the standard. All patients got oxygen. All patients got oxygen. It can't hurt you. It's just oxygen. And now, as research and evidence comes out, it turns out that there are a large population of our patients that if you give too much oxygen to, it could actually make it harder for them to breathe. And we will talk about that when we get to respiratory and ventilation. So levels of EMS training. Starting at the lower end, we have the emergency medical responder, EMR, also used to be called the first responder. They're trained in some elements of basic life support, some similar elements of basic life support that the EMT is trained in. A big difference with the EMR is that they are not able to solely provide patient care during transport. And what I mean by that is they can arrive on scene first. A great example of this would be like a volunteer firefighter that's an EMR. They could arrive on scene first, start doing assessments, start doing patient care, but they cannot be the only person in the back of an ambulance taking somebody to the hospital. The next level is emergency medical technician. This used to be called EMTB or EMT basic. It's now just emergency medical technician. That is what we are studying to be right now. This is our class. The distinguishing thing with EMTs over EMRs is our level of assessment is much deeper than an EMR. We do have some more treatments in our scope of practice, depending on which hospital system you practice in. And we are the first level that is able to provide patient care 100% by ourselves. We don't, or I'm sorry, we are able to transport somebody to the hospital being the only person in the back of the ambulance. Just above us is an advanced emergency medical technician. This is basically an EMT who took a extra class that goes over certain advanced life support practices that paramedics usually have. An example of this would be starting IVs. And then we have paramedics. Paramedics are the highest level of training. They are advanced life support. They have a whole slew of different treatments that they can do, and we'll talk about that as we progress throughout the course. Okay, so what are some of our roles and responsibilities as EMTs? First of all, it's important that we keep ourselves safe. Um, when you go on a bad call, the adrenaline starts to take you over, and it's not hard to run into a call and have tunnel vision. But if we get hurt or we get killed, we can't help the person we were there to help. So keeping us safe is the first step. Safety of the patient, safety of the bystanders is also our responsibility. And then we dive right into patient assessment. And by the time you guys are done with this course, you're going to hate the word assessment, because that's what we're going to be doing for a large part of class, learning how to assess patients. If you can provide yourself with good assessment skills, the rest of the course really will sort of just fall into play. Assessment truly is the foundation for everything. We're responsible for any patient care that we give or we perform, especially if there's not a higher level of care there. So if you are working on an ambulance with a paramedic and the paramedic's providing patient care and you're assisting, the paramedic's ultimately responsible for all treatments that are given to that patient. But if you are working on an ambulance with another EMT or a driver, you are responsible for everything good, bad, and ugly that happens to that patient. Um, we'll clarify what I mean by that in class. We'll clear that up a little bit. But the big picture here is that it's very important to have a reason for what we're doing, because we are responsible for our actions. We are responsible for knowing how to lift, move, and transport patients without causing further injury to them or to ourselves, transferring care at the receiving facility, and then being patient advocates. So this is just a very, very quick think about it. Um, how would it impact an older adult patient if they were transported to the hospital without glasses, hearing aid, or dentures? Well, I mean, in certain emergent situations, these little things are the last things on our mind. And I'll admit that that's very rarely something that crosses my mind as well, but it is part of our responsibility to think about these things. You know, we may take a patient to the hospital experiencing chest pain, and they stay overnight. But if they don't have their hearing aid or dentures, how much worse is their night going to be because we didn't grab it out on our way out the door? So this is almost a given. Patient advocacy absolutely extends to the community, like I talked about before, with the smoke detector campaign, the carbon monoxide alarm campaign. It's our role to try to prevent bad things from happening. We respond and we react when they do happen, but we have to also fulfill the role of prevention. Okay, so this is just a slide that was put in by your textbook. Some of this, you could agree to disagree with, but it is important to be in decent physical shape. We do a lot of lifting, a lot of moving. It's important to be able to see well, so you can read medications and you don't get hit by a semi when you're crossing a red light. And then good communication skills. That's probably the one that I definitely stand by the most on this. We have to be able to communicate with patients. We have to be able to communicate with others. We have to be able to communicate with the hospital. If you can't communicate, you're not going to be very good at what you do with your job. We were all very, very shy at one point when we started this. And to a lot of ways, I still am. But it's very, very important that you put on at least that face when you walk through the door of your patient's house, that they are going to sense somebody who's confident in their skills, confident in their communication, and that they are in good hands. They don't want somebody who's, on their first day of the job, somebody who's unsure of themselves. They want somebody that can communicate exactly what assessment questions they want answered to the patient, and somebody who's going to communicate exactly what they're going to do to make all that patient's problems go away. So personal traits, we have to be pleasant, sincere, cooperative, and resourceful. All of our patients get tested, and patients as in my mental patients, not my physical patients I'm taking care of, but we all get pushed to our limits at times. Um, I mean, at some point in your career, you will be, cussed at, yelled at, kicked at, hair pulled and spit on. But if we're not pleasant, sincere, or resourceful with the situation that we're in, we're not going to make the situation any better for the patient or for ourselves. I'm going to skip through a couple of these because they all go hand in hand. They are available in your textbook. So education. So you guys are about to go through a 16-week class. After this class, you guys are going to have to take a state skills exam, and then you're going to have to take the national registry, all before you can practice in the state of Indiana or anywhere. After that, you're not off the hook. You have to maintain a certain amount of continuing education hours every 2 years and submit them to the state. Otherwise, your license will, like in a sense, expire. You won't be able to practice. So it's important that we maintain an up-to-date knowledge about skills and treatments and pathophysiology as we continue. Because what happens far too often is we go through the class, we study to remember answers for the test, we take the test, we forget, we get that license or we get that certification, and we stop. We got it, we're EMTs, but we don't push ourselves much farther beyond that. So then we get EMTs that have a certification that don't actually know how to be an EMT. They just have a piece of paper that says they are. Or we get EMTs that have been doing it for 20 years but don't stay up to date on the current research and the current standards. And they're doing treatments that are either harmful or not helping our patients at all. Okay, so this just talks about, a few possibilities of where you could work. A lot of you will probably start off working for a private ambulance service. Um, that's kind of where a lot of EMTs start. That's where the baby EMTs go. The good thing about working for a private service is that you really, really, really get good at your patient assessments because you end up seeing the same patients over and over again when you transfer them from nursing homes or doctor's appointments, and you could see how their health conditions change every time you take them. Volunteering is a fantastic idea to do. It's something I really encourage you all to do. It's exactly how I started, and it's something I'm still very active in doing. You get to see a wide array of patients and situations that you may not be able to see anywhere else. So, the National Registry of Emergency Medical Technicians, this is going to be the organization that's going to make you guys want to pull your hair out for the rest of the course. So, the National Registry is a registration for EMRs, EMTs, AMTs, and paramedics who successfully complete the NREMT exams. So you guys will not have a choice. When you're done with this class, you have to take the National Registry. The state does not maintain their own EMT exam anymore. They only accept the National Registry. The perks to having a National Registry um, for you guys would be it makes it easier to go get a certification or a license in another state. If the state's also accepting the National Registry, then all you have to do is fill out reciprocity paperwork. You don't necessarily have to retest. Um, the National Registry, you'll understand why so many students get stressed out with it. There's truly nothing to be stressed out about. It's just a different way of thinking, and it's a different way of taking test questions and analyzing them and coming up with an answer. All of your tests you'll have throughout this course are National Registry style questions, so you'll get used to them real quickly. Quality improvement. So, like I said before, we have to maintain this continuous review of ourselves. Whether it's me being the boss of an organization or me just being a provider, and after the call, sitting back and thinking, "Huh, what could I have done differently?" Or if I had a bad outcome, did I do everything I was supposed to do? Um, Only for the purpose of making sure that I improve over time. We don't like to second guess ourselves in our jobs that we do, especially after the call is over. Oh, I wish I would have done this. I wish I would have done that. That's not a good thing to do. But for future calls, understanding, okay, I did this and this worked well, or okay, I did this and this probably could have been done better, will help us improve on future calls. So we have to remember that everybody on the organization has a role, um, all the way down to John Doe, the volunteer firefighter who has never seen the inside of an ambulance but shows up to help you, all the way up to medical director, doctor. Everybody has a role, and it's important to include everybody. And it's also important to implement quality improvement amongst everybody. How could John Doe, the firefighter, have helped better on that call with moving the patient? Or how could, Dr. Smith, the medical director, have better organized what he wants us to do in his protocols? Okay, so medical direction, all patient care that's performed is performed under the direction of the medical director. What I mean by that is that the doctor or nurse of the sponsoring hospital is ultimately responsible for patient care. Any treatment that I provide or any treatment that any EMS licensed person provides is being done under the license of that doctor, which is why it's very important that we follow what that doctor wants us to do. Um, we have offline medical direction and online direction. The offline medical direction would be your protocol or standing orders. Every ambulance you work in should have a protocol book that outlines pretty much every scenario that you could think of, every condition or patient presentation, and it tells you, okay, for this, you got to do this, 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 and this. This is how much of this drug, this is how much of this drug, and you're going to stabilize this. Um, for online medical direction, it fills in all the cracks in the offline direction. So if there's a scenario that I am just completely lost on, it's not clear in the book, I'm unsure of myself, I just want to double check, or I'm tired and I forgot, you can always call home and call your medical director. You call the hospital, you ask to speak to medical direction, doctor picks up the phone. Hey doc, this is so and so from Wheatfield Ambulance Service. I'm on scene with this patient. This is what happened. This is how they present. This is what I did. I have a question about this. What else would you like me to do? Okay, so we already talked about the EMS role in public health, primary prevention, disease surveillance. So it's just something we need to keep in the back of our minds. If we're having the same patient that's falling 7 times a week, is there something that we can do when we go to her to try to prevent her from falling again? Okay, so we're coming to the end of our journey here for the chapter one presentation. These next few slides just talk about the research components of EMS. I'm going to let you guys read this over in your book on your own, just because otherwise I'm going to start talking and I'm never going to stop talking. And I don't want you guys to have to listen to me any more than you have to. Um, Research in EMS is important because it gives us areas of focus for where we can improve and what we need to do to be better in the future. Um, Go ahead and look through the rest of your book on this, read about it, write down a bunch of questions, and we'll talk about it. This is not a high testing topic. You will not be tested on this. So, like level of evidence 1, 2, 3, 4, and 5 is not something that you will need to know for exam one. I just want you guys to have a very broad, general understanding of what research is, why we do it, why we should pay attention to it. And other than that, that's going to sum up chapter one for us. Um, I do expect you all to have read chapter one by Thursday. And hopefully you have viewed this if you've gotten to this point. And I would like you all to at least have one question or something that you want to discuss on Thursday. We'll dive a little bit more into it then. All right. That's it. If you have any questions, like I said, just send me an email. All right. Thanks, guys.